Afternoon, everyone. At the outset, I would like to thanks to the organizers of Medicine 2025. My special thank to Professor P.K. sir for this kind invitation, which is a truly regard and truly honor for me. So the topic allotted to me is of very practical importance, and it is relevant to present trend of the practice. A difficult patient having multiple comorbidity admitted to your hospital is not having money but admitted to your intensive care unit with a lot of expectations. So respiratory failure is one of the commonest emergency which we see as a physician, as a pulmonologist, as a cardiologist, or any critical care specialist. So I'm going to talk about this, how respiratory failure can be managed with minimum intervention and limited resources by a skilled physician. So I will talk a little bit of science, then I will talk a little bit of practical aspects. So the aim of presentation is a clinician should be able to diagnose acute respiratory failure and manage adequately in the limited resources and in small ICUs. And I will discuss my topic in 4 headings. First, I will talk about what is respiratory failure, then what are the common etiology of respiratory failure which we see in the day-to-day practice, and then the various intervention for the management of these patients and how I can make my treatment cost effective so that I can reduce the treatment cost and I can satisfy my patient as well with the limited resources, which is a challenge for the clinicians. So by definition, the respiratory failure is a syndrome in which the respiratory system fails in one or both of its exchange function, means oxygenation problem, or it may be a carbon dioxide elimination problem. So once there is a problem of oxygenation, what we call as hypoxic respiratory failure, that is type 1 respiratory failure, where the PaO2 is less than 60 in ABG. And when it is primarily hypoventilation, means the hypercapnic failure, this is called as type 2 respiratory failure, which is very, very common in intensive care unit when the PCO2 is more than 50. And sometimes both can occur in the same patients. Now, some of the studies, some of the books, some of the texts, they say that the type 3 and type 4 respiratory also exist. The type 3 is secondary to the lung atelectasis in perioperative procedures when the patient in the supine position with the relaxant sedation, the raise the diaphragm, that decrease 30% of the vital capacity in post-operative periods, they have a hypoxia. This is called a type 3 respiratory failure. And the type 4 respiratory failure, many patients of the sepsis, they initially admitted with the hyperventilation because of lactic acidosis. So sepsis related respiratory failure is called as type 4 respiratory failure. So coming to the practical aspects, what are the commonest reasons of these patients presented with acute respiratory failure? If we see in a day-to-day practice, the COPD exacerbation is the commonest reason, and second is ARDS, pneumonia, cardiogenic pulmonary edema. These are 3 clinical conditions which account for more than 70% patients of respiratory failure and a medical ICU. Although the obesity-induced hypoventilation, interstitial lung disease, immunocompromised patient with sepsis, post-operative failure, asthma can occur in some of the patients. So if you see this patient, it's a case of COPD you can see here. The advanced emphysema and frequently admitted with the hypercapnia to your intensive care unit. And this is pneumonia. These patients, most of the times they are admitted with sepsis and hypoxic failure, the type 1 failure. This is the case of the ARDS and this is the case of acute pulmonary edema. What I am showing this X-rays because just by clinical history and seeing this X-ray, a clinician will be able to diagnose at bedside that my patient is having type 1 failure or type 2 failure, where I should move, in which direction my treatment should move. So this is the first investigation which we do in our patient, and most of the time the patient is coming with this X-ray. So just by seeing this X-ray, seeing the saturation, you can make a diagnosis whether your patient is having type 1 failure or type 2 failure. So it is a very practical problem. This is a challenge. You have admitted this patient the critically ill, you have limited resources. You are not having everything in your ICUs, and most of the Indian ICUs, leave the 5-star hotel type of hospitals, but the small ICU, 70% ICU in India is resource limited. Only the 30% ICUs are having all facilities. Single clinicians, 3-4 nurses, and 1 technician, 1-2 intensivists. They are managing these patients. So it's a very practical problem. So more important is there is no money, and attendants are waiting outside. Up to admit kar diya, it is your responsibility. You have to manage it. It's everyday problem. If patient survive, it's okay. If the patient not survive, then the problem. It's difficult for the clinician as well as more important for the hospital administrator. So challenges are in infrastructures. We have the limited bed. We don't have the good quality ventilators. There's the oxygen supply, power supply, nursing staff, trained person. Manpower is very, very difficult. And the most important is the patient-related factor, the financial factors. In minimum, in any ICU, cost of therapy is not at 20 to 30,000. In my ICU, it is more than 1 lakh, on average 1.5 lakh per day. You can think about how a patient, a middle-class family can spend his money. And patient is unable to understand the disease. वो तो आपके पास आया, आपकी जिम्मेदारी है. And attendant attitudes. सर जब आए थे तब तो बात कर रहे थे, अब आपने ऑक्सीजन लगाया, कार्बन डाइऑक्साइड रिटेन कर गया, CO2 बढ़ गया, वेंटिलेट हो गया. What happened to this? जब हॉस्पिटल आए थे, he was talking. Whatever you do, but it's very difficult to convince them that this is a disease process which is rising. He admitted in early stage, he will deteriorate. So these problems are very, very difficult to manage in clinical practice. So coming to the management, how to manage a patient of respiratory failure, 3 important things. First, treat the underlying condition. Second, the supplemental oxygen therapy. And third is invasive ventilation or non-invasive ventilation. The 3 important points which we have to understand. So oxygen is the most important drug. I'm saying this most important drug to treat these patients and use judiciously. So target of oxygen saturation should be individualized based on underlying disease. Like in COPD patients, most of the patients, they are comfortable with 85 to 95% saturation. And the target in ARDS patient, it should be 88%, not the 100%. It's a very common problem in ICU. They try to increase the oxygen 99 or 100%. Nobody is having 99 or 100% oxygen. Hyperoxia is as harmful as a hypoxia as well. In pregnancy, this is again very important. Minimum saturation should be 94%. And many patients are comfortable at 80%, especially if somebody is having obese and obesity-induced hypoventilation. So you put on probe in even your clinics, saturation is 74, patient is sitting comfortably. What I mean to say that, so titration of oxygen, this important drug should be individualized depending upon the patient clinical situation. Because hyperoxia is as important as hypoxia. So giving more oxygen is very dangerous, especially in the patient with a type 2 failure. What happened in these patients, when you admit the patient, he was conscious, you give him the uncontrolled oxygen, suddenly the suppression of hypoxic drive, CO2 raised, unconscious, ventilated. So oxygen should be given guarded to these patients. So whenever you see patient in ICU, you always look for FiO2 and saturations. How much your patient is having, don't keep it 100%. Whenever I go to the ICU, many times it is 99 and 100%. It should not be. It should be more than 90%. So these are the various methods by which we can give the oxygen. This is your skill that in this patient, what device, what oxygen, what instrument I have to apply, because every intervention is having the different flow and FiO2. Like in the nasal cannula, you can give only 30% oxygen, and with mask you can give the 40%, with non-breathable mask you can give 80%, with HFNC you can give the 100%. So depending upon the requirement, you have to select the device. You cannot put the patient of COPD on HFNC. There is a nasal cannula is adequate. Just try to increase oxygen saturation 3-4%, that is adequate for these patients. So many times we see in ICU, oxygen is saturation is 100%. It should not be. It is important drug. Save the drug. Save this oxygen so that you can supply it, you can give to some other patients. Now coming to the second part, ventilator support in acute respiratory failure. That may be invasive and non-invasive. So our target is to avoid invasive ventilation with your all effort, whatever you give. Whether you give the oxygenation, whether you give non-invasive ventilation, whatever you do, but prevent intubation in that patient. Because once the patient is intubated, definitely the cost of therapy will increase and there will be the problem. So I'm very fan of this non-invasive ventilation because in the last 20 years, this is one intervention that has completely changed the management of respiratory failure. It's a boon for type 2 failure, especially the COPD patients. The use of non-invasive ventilatory supports has increased dramatically in the last 20 years due to availability of more accessible interface and desire to avoid complication of intubation. So when the patient is in intubation, the cost of therapy will increase. You have to give the sedation and the probability of developing ventilator-associated pneumonia. The cost will again increase 3 times. So how to select which device? So BiPAP support is one, HFNC is one, which I will talk. And third is BiPAP support by critical care ventilators and avoid your patients from intubation. So these are 3 things which you can apply to your patients. So clinician skills matter. Which patient needs which support? That is your skill, that is your experience. So target that my patient should not go on the step 4, that is ventilations. If it is needed, it should be done, but efforts should be done to prevent the intubation of these patients. So choice of the respiratory support depend upon the type of acute respiratory failure and the severity of the disease. All interventions are having their merits and demerits. You should be aware of these things. So these are fact, lot of literature, and there is no question mark about the indication of non-invasive ventilation and success of non-invasive ventilation in 3 indications. One, it's acute exacerbation of COPD. Second is the cardiogenic pulmonary edema, and third is obesity-induced hypoventilation. A lot of literature. There is no question mark, no and if and what. It should be given to these patients. And BiPAP support and NIV support in these indications like asthma, ARDS, pneumonia, interstitial lung disease, and post-operative respiratory failure is your decision. This is not contraindication, but not the preferred mode of choice because they are having primarily hypoxic failure, and these patients most of the times having the hypercapnic failure, where the NIV is a boon for these patients. So coming to the clinical subject, that is acute exacerbation COPD, which is the commonest indication of hospitalization of these patients in intensive care unit, especially in care of the physician. A recent international consensus conference recommend it should be the first line treatment. When you are treating bronchial asthma, inhaled bronchodilator is the first line treatment. But if you are treating a patient of acute exacerbation of COPD, first line intervention is NIV support. More important, it should be applied early. Because once the patient is at the decreased pH, increasing PCO2, muscles will get exhausted, there will be lactic acidosis, decrease in the pH, and the patient will collapse. So start NIV support as early as possible. So these are the 2 learning points. So NIV and COPD exacerbation not only save patient, but also the cost of therapy and hospital stay. Because in most of the same patients, in more than 70% patients, if you are involved actively, you can save intubation in patients. You can manage these patients with NIV supports. It's approved worldwide. First line intervention with as early as possible in case of acute exacerbation of COPD. So there is only one indication. Patient should be able to protect his upper airway. Any patient of COPD admitted with your hospital with acute exacerbation, only one prerequisite, that patient should be able to protect his upper airway. Rest there is no contraindications. All the relative contraindications are here. The respiratory arrest. Patient is having respiratory arrest. Do not apply NIV. The patient should be intubated. Severe encephalopathy, whatever the region. Upper GI bleed. Suppose a patient is upper GI bleed, you have put the BiPAP, the patient will get aspirate. And atrial sensorium, recent arrhythmias and cardiac arrhythmias. The relative contraindications are severe hypoxic respiratory failure, large copious secretions, and previous failure to NIV, hypertension, hemoptysis, the relative contraindications. The patient is able to protect his upper airway, he is conscious, you can apply this NIV whatever the level of the CO2, whether it is 80, 90 or 110. If the pH is more than 7.2 and patient is able to breathe, you put the BiPAP on these patients. Recently it has been shown that hypercapnic coma, this is one indication. Patient is unconscious because of the CO2. Then you can apply the BiPAP. And in rest condition, if the patient is unconscious, this is contraindication. So hypercapnic encephalopathy is one indication of NIV. You can give the trial for 1 hour because by which you can decrease the CO2 and your patient becomes conscious. So now how to apply? We have two things. One is the plain BiPAP, which we can apply in the emergency ward, we can apply in ICU, we can apply in the general ward as well. Because there is no technical skill, you just need a trained staff who can apply this. If your patient is having high oxygen demand, means there is both failure. Patient is fully conscious, but the demand of oxygen is quite high, the CO2 is rising. So in that condition, it's better to give the NIV support by critical care ventilation. Reason being, because when you give the BiPAP, with the BiPAP you can give the FiO to 30 to 40%, not more than that. But if your patient is hypoxic, then you have to give the NIV support by critical care ventilation because you can control the FiO2. You can control the ventilation, both the conditions, but FiO2 you can control only in patients when you are putting this BiPAP support, the critical care ventilators. And how it works. This slide is basically for the resident who are sitting on the back side. So whenever you start BiPAP, it's a very simple thing. You have two pressure. One is the EPAP and second is IPAP. EPAP means expiratory positive air pressure. Second is inspiratory. IPAP is inspiratory airway pressure and EPAP is expiratory airway pressure. So when the patient start breathing, there is the fluctuation of the pressure. So function of EPAP is just to keep an alveoli open, keep it open, right? And this function of IPAP to increase the tidal volume. So suppose your patient is having high PCO2, you increase the gap, you increase IPAP. The function of IPAP is to increase the tidal volume, so can you remove the carbon dioxide. If your patient is also hypoxic, you increase the EPAP, but keep the gap at least 4 to 5 between this, otherwise the machine will not trigger. So IPAP is basically for carbon dioxide removal because it increases the tidal volume, and EPAP is basically for hypoxia, to open the alveoli and keep it open. This is basically PEEP. So how to monitor the patients? The simple thing, just see the respiratory rate and tachycardia. Tachycardia is very, very important sign. If somebody is having heart rate 130 and after putting the BiPAP, the first sign of improvement is a learning point, the heart rate will decrease. Heart rate will decrease. Second thing, put your finger on the sternocleidomastoid muscles here. See how much stress it is before putting the BiPAP and after putting. If you get relaxed, it means the work of breathing is decreased and your BiPAP is effective. And don't see the ABG for improvement. There's only two things. One is the tachycardia and the pressure in the sternocleidomastoid muscles that indicate your patient is improving. So ISCCM recommendations, there are 3 important points. If your patient is having the pH less than 7.35, it should be applied. Or PCO2 more than 45, NIV should be applied to these patients as early as possible. Although if a patient is having normal pH, you can apply this, but there may be not any harm to these patients. If pH is less than 7.3 and he is hemodynamically stable, it is better to apply BiPAP but keep the patient in ICU. So there should not be hemodynamic instability because the patient deteriorates very fast. It's an improved fact. Coming to the second indication, So second indication is is a very common emergency, especially in the medical ward and medical ICU, the acute cardiogenic pulmonary edema. Again, I am showing this X-ray. The good clinician who put on his steth on the back and see the X-ray, see the pulse and the blood pressure. After seeing these two X-rays, they easily can make the diagnosis that my patient is having the cardiogenic pulmonary edema. This patient with the cardiomegaly, means the ejection fraction is not more than 20%, and that patient in the primary diastolic failure, heart failure with the preserved ejection fraction. So X-ray is very, very important because everybody is not cardiologist, everybody cannot do the echocardiography, you don't have the facility to do the cardiac triage or BNP. So just seeing with the X-ray and putting a stat on the back, you can make a diagnosis that my patient is with systolic heart failure, this patient with the diastolic heart failure. So because echo and BNP is not available everywhere, so X-ray is a very, very important investigations by which you can save a lot of money, because everybody is not having an echo in your intensive care unit, in your ward, in your hospital as well. So NIVs again is a wound for these patients. If they are not hemodynamically very unstable, they are not having the past recent history of myocardial infarction, because in this condition, the cause of the heart failure is increase in the preload and increase in the afterload. And NIV do affect both the condition, that decreases preload and decreases afterload. That is unloading of the heart by the bipap. And most of the patients, they have positive result when they're putting patients on bipap and diuretic. You can see this patient is a case of acute pulmonary edema, and after putting on the bipap and diuretic, patient recovered within 6 hours. So there's a lot of literature, evidence. This non-invasive ventilation acute cardiogenic pulmonary edema, patient has a fast recovery, or the long-term mortality is not affected. But a lot of literature is there. Now the question is, if my patient is having cardiogenic pulmonary edema, should I put the CPAP and BiPAP? Remember, if your patient is having purely hypoxic failure, the CPAP is the best option. It's a proven fact. If your patient is having also raised PCO2, like in a patient of asthma, COPD or bronchiectasis or post-tubercular fibrosis coming to you with pulmonary edema, so possibilities there may be increase in PCO2 as well as decrease in oxygen. So type 2 failure is there. Then you should prefer the BiPAP, because the BiPAP increase ventilation, decrease in the PCO2. Otherwise, CPAP is much, much better in these patients, because in the BiPAP you have to apply the full face mask, and the patient the high respiratory rate, and most of the patients they have a claustrophobia, is very difficult to manage. But putting the nasal mask is very comfortable for these patients. So role of non-invasive ventilation acute cardiogenic pulmonary is a very good article, and say there is no difference in management of cardiogenic pulmonary edema whether you are applying CPAP and BiPAP. But it is said, and it is practically we have seen, if the PCO2 is raised, it is better to put on a BiPAP rather than the CPAP. So ISCCM recommendation is, the CPAP is recommended in addition to the standard medical treatment in case of the cardiogenic pulmonary edema. CPAP or BiPAP are equally effective. BiPAP is preferred when the hypercapnic failure is there. The third condition is ARDS. It's definitely, there's no doubt about that, the treatment of the ARDS is invasive ventilation. In the last 10 years, we have a lot of learning, lot of experience management of ARDS with the non-invasive ventilation as well. This is the Berlin definitions. According to this definition, you can see here that the 4 important components, the timing, that insult should be within 1 week, there should be bilateral infiltrates, and origin edema should be from the respiratory, not from the cardiogenic, that you can do by echocardiography, and then we have to classify the ARDS. But what happened with this definition, this is a little more cumbersome for the clinician to apply the bedside. And the lung safe study say that we apply this study, and 30% patients we cannot make the diagnosis of ARDS, especially in the early cases. So for a clinician, it's very, very difficult to do echocardiography in every patient. So new definition, that the global definition, this definition is basically for the poor countries, for resource limited countries. And so they have applied that. There is no need for doing the AVG even. If you suspect your patient is having hypoxia, just put on the pulse oximeters and you can calculate the SF ratio rather than PF ratio. In PF ratio, you have to do the AVG, and by these definitions, we can make most of the diagnosis, and we can detect more than 90% cases of ARDS bedside without any investigation. That just by pulse oximeter. So this is the poor man definition. So role of NIV in respiratory in ARDS, NIV may be useful at appropriate selection of patient in hypoxic failure. And it should be used in hypoxic respiratory failure only in ICU, not in the ward, because these patients have the very poor respiratory result. If you apply this BiPAP or CPAP or oxygen in the ward in hypoxic failure, the patient they deteriorate very fast. You don't have the time. So whenever there is a primarily hypoxic failure ARDS, better to put in the ICU. Then you can apply the BiPAP. So coming to this device, because this is a wonderful device, and we have used a large number of patients after the COVID, and this was the boon for the COVID patients. And after that, every hospital is having this. And I suggest everyone who is running their hospital, they must have HFNC in their hospital. Although limitation is they need a lot of oxygen. If you have central supply, the wonderful device by which you can save large number of patients with ARDS. So HFNC stands for the high flow nasal cannula, the type of respiratory support therapy that deliver high flow of heated and humidified oxygen by nasal cannula. It's an alternative to the conventional oxygen HFNC and primarily indicated in patients of hypoxic respiratory failure. So HFNC is very simpler to use. It's more simple as compared to NIV supports. HFNC is better tolerated with NIV because there is only nasal mask, it's very small nasal prongs, and deliver high oxygen up to 60 liters per minute. And it's very good option for the hypoxic failure, especially a patient who is hemodynamically stable. It generates a low pressure PEEP, 4 to 6 PEEP can be generated, but not more than that. And wash out the dead space, increase PCO2 and decrease PCO2 as well. So unloading the respiratory muscles during the acute respiratory failures, we have used in large number of patients, and we have saved significant number of patients only because of this device and because this presentation was very, very common in these patients. So these are the indications you see here in HFNC, the hypoxic respiratory failure, all type of hypoxic respiratory, post-activation support. You have extubated the patient, your patient may have having significant hypoxia, put off an HFNC. Pre-intubation oxygenation, the demand of oxygen is very high in patient. You don't have the result, put off an HFNC, then you intubate the patient, and do not intubate the patient, DNR patients. If you want to continue, because oxygen is should be given to whatever decision you have taken, but the oxygen should be given to these patients. Cardiogenic pulmonary edema, immunocompromised patients, viral pneumonia, even in some of the patients of the COPD, where the COPD exacerbation is because of pneumonia, because the demand of oxygen is more there. And that conditions we can use HFNC. Hypercapnic failure we should not use in this. Some modification and adjustment in respect to the resource limited. This we have learned with the time. So this is one technique, what we call as BiPAP with the leak valve. So there is a so what happens sometimes the patient is a ventilator for 1 month, or you are not able to wean off these patients and it is fully conscious, hemodynamically stable, but because of the critical illness for the neuropathy, there is some demand of ventilation. So this is one technique what we are doing, we are connecting this leak valve with the BiPAP. And then we can transfer the patients. This is very economic for the patients. You can shift the patients to the HD, or you can shift to the general ward with the BiPAP machine with the complete paralysis, because there's a lot of support with the BiPAP and leak valve. You are not supposed to send the patient with the ventilator. Second is, this is our new concept is generated, developed with my PG resident, DNB resident. What happened? And I have learned with this technique. Many patients, especially like this lady, is the case weight is near around 120 kg. She is an overlap syndrome, having obesity-induced hypoventilation, OS, and CO2. And CO2 is only every time it is more than 100, 120, 130, and we put on BiPAP fully conscious, but we are not able to decrease the CO2. So what my resident did in the night, he put the collar here, and what happened then? After 6 hours, we repeat this AVG, the CO2 decreased about 30%. Then I understand, and I try this again the second patient. So this is one technique by which we can do what happens when your patient is breathing like this, because a lot of pressure in the upper airway, the air is not going into the lung, so there is ineffective ventilation. We are not able to remove the oxygen. But he put the collar like this, the ventilation will be there. So this is one method by which we can decrease the CO2 in many patients, especially in the obese patients who are suffering with obesity-induced hypoventilation. So this is my last slide. Evidence practical tips, preferred option for respiratory failure and acute respiratory failure, respiratory support, how you should select. If a patient is primarily having hypoxic respiratory failure, HFNC is the option. If your patient is having primarily hypercapnic failure, try to give NIV, whatever effort you do, so that you prevent the intubation of the patient. So acute respiratory failure is very common emergency. NIV is recommended as a first line option treatment of respiratory distress in COPD and cardiogenic pulmonary edema. There is no question mark. CPAP is the preferred option in the cardiogenic edema. If PCO2 is raised, apply the BiPAP. So lack of training and experience in NIV may explain the lower rate of NIV implementation. It should be done. Train your staff and again. And the key of success of NIV application is using the right patient and the right device. HFNC is one option for hypoxic respiratory failure with a reasonably good result, a very good result in hypoxic failure. Everybody should have this machines. So clinician has to spend more time and use your clinical experience to avoid intubation and cut down the cost of therapy. If you apply this knowledge to your patients, a large number of patients, you can prevent the intubation. Thank you very much.
Thank you, sir. Congratulations and thank you for such a wonderful description and explanation in a practical way. Basically, in your resource limited setting, now forum is open for discussion.
Dr.A.K.Singh was very nice talk, very informative.
Thank you, sir.
Oxygen therapy, there was a concept that in 24 hours in COPD patients, how many hours will be better of oxygenation in 24 hours?
So you are talking about the long-term oxygen, minimum 18 hours. If you want to change the result, if you want to increase the survivability of the patient, it is 18 hours should be given. Plus, this is not one values that depend upon the person's requirement of the oxygen. But your target should be near about 90.
So, if we are giving more than the 20 hours of oxygen, that was the harmful. Better was the 18 to 19 hours of
18 hours. 18 hours is recommended, but in the old guidelines.
In old guidelines.
But you have to individualize your patient, but that saturation should be more than 90, 91, not more than that, whether it is 1 liter or 2 liters. So 6 to 8 hours you can give, but if you want to change really outcome, you want to decrease the pulmonary hypertension, it should be 16 to 18 hours in a day 24.
Intermittent oxygenation was also better.
No, an intermittent oxygen is not having no role.
Sir, how to keep the oxygen, how liter much, how to keep the liter, how much oxygen has to be given? 2 liter, 3 liter,
So,
how to calculate
right.
this?
So there are the different devices which I have shown. If
Yes.
you are giving the nasal cannula, by which you can give the only 30% of FiO2. So you can give up to 5 liters. By nasal cannula, you cannot give more than 5 liters. Suppose we are giving the non-breathing mask, by which you can give 100% oxygen, you can go 15 liters. If HFNC, we can give 100% oxygen, 60 liters. That depends upon the what type of patients you are managing. Right.
Session, and I hope this is also available on your YouTube channel because
बढ़िया Good clear. Very
and I request Dr.A.K.Singh to please participate the chairperson.
Yes, sir. Thank you.
So next to overcome by Dr. Sajid Ansari. And for this I would like to invite Dr. Praveen Kumar, Dr. Rajiv Kapoor, myself, Dr. Sunita Bhadolia, Dr.
Yes, sir.
Kshitij Nath and Dr. Rajiv Kumar Jain to please.
Yes, sir. एक बार आप लोग सारे लोग साथ में आ जाइए।
कोई नहीं बात।
हमारी
Yes, yeah, देखिए सर. Thank you, sir.